as a lesson to us to advise the women to take proper care of herself. So when we are looking at hypertensive disorders of pregnancy, that were different. When we classify hypertensive disorders, there are many types of hypertensive disorders. More basically, we classify them into gestational hypertension, pre-eclampsia, eclampsia, chronic hypertension, and chronic hypertension with superimposed pre-eclampsia. We know chronic hypertension is pre-existing even before the pregnancy, whereas gestational hypertension and pre-eclampsia happen during pregnancy. So they again, although they happen during pregnancy, they also can be a consequence of already existing inflammatory, metabolic, or genetic issues which are there in that particular woman. So what they have noticed is that if the woman has 2 pregnancies with pre-eclampsia, there is a 3 times increased risk of developing hypertension. She has an increased risk of developing stroke, ischemic heart disease, heart failure. All these are been studied, and they have also seen that there are cerebrovascular accidents, more of a risk of cerebrovascular accidents, hospitalization, and of course, kidney disorders, needing dialysis. So end-stage renal diseases also have been noticed in some of these. Although this slide is a little showing it a little more, maybe a little exaggerated, but it has been studied in some way, one particular study, and this is the statistics they have given. But basically, what we need to understand is that there is an increased risk for these women for developing hypertension in the future. So what we have to do in such a state? So in this pregnancy, pregnant women who is already having a pre-existing chronic hypertension in the postpartum period, when she comes to you, you have to continuously follow her up till she becomes a and record her hypertension. So if within 6 weeks, if she is reverting to your normal hypertension, with the normal blood pressure, then you just have to ask her to have a regular follow-up of her blood pressure and in any clinic and on and off, so that she'll have a early diagnosis if she is going to develop hypertension in future. If the patient is a chronic hypertensive, then after lactation, during lactation also, we don't give some medications like the pregnancy, in pregnancy specifically, we don't give any ARBs and we avoid certain medications. So after delivery, you can revert back to whatever hypertension antihypertensives they were on. But it is very important to follow them up and see if there have been additional changes which have happened because of the pregnancy. So close follow-up of these women because of the risks that they are going to have. You see the whole list. So when you know that this is there, it is important that you counsel the woman. So the most important part here is about counseling, whether it is preconceptional counseling or postpartum counseling. So regarding the long-term consequences and how she has to come for you for a regular follow-up, and she can record her blood pressure at any clinic at any point of time over the years. So also, other than that, there is another important medical non-NCD, that is a non-communicable disease, which is there, which is very prevalent in our country. That's diabetes. And we all know pregnancy is a diabetogenic state. But as such, diabetes in its early weeks does not cause any major impact on the woman. So we have seen that usually where women go, I mean, any person, not only a woman, any person, diabetes goes unnoticed because it has long-term consequence. Most of the time, it goes off, it's a silent disease. Very rarely, patient has vague symptoms like polyuria, polydipsia, all such polyphagia, all these things, sudden weight loss, obese women suddenly loses weight because it's uncontrolled diabetes. All these sequences have to happen for a woman over a period of time, for a woman to think that maybe I'm diabetic, for a woman or man to think maybe I'm a diabetic and then go for it, or go to a doctor who can predict that probably these symptoms are reflecting her probable underlying diabetic condition. So one of those things is again what we call as GDM. GDM is gestational diabetic mellitus. Gestational diabetes mellitus, by definition, means a diabetes which is first recognized in pregnancy. So unlike hypertensive disorders, where it is first recorded and in pregnancy after 20 weeks, then only call it as gestational hypertension or preeclampsia. But whereas in diabetes, even if she had been an overt diabetic, but first time it is recognized in pregnancy, we call it as gestational diabetic mellitus. To avoid confusion, you can also use hello. Okay. So you can also use another terminology which is known as hyperglycemia in pregnancy. So basically we all need to recognize because of the multiple hormones that are there in the women that are happening because of pregnancy, there is going to be an increased risk of developing diabetes. So when they followed, this is one of those studies again, where they followed 675,000 women for 28 years, they have found that there's a 7-fold increased risk of developing type 2 diabetes in these patients who are already having gestational diabetes. They also have, what are the consequences of diabetes? I did not tell you that these women are at increased risk of developing cardiovascular symptoms and they have a greater prevalence of proteinuria when compared to the other women without diabetes. So all these are a part of the probable complications of gestational diabetes. So what do you do? So is it enough for us to recognize and then counsel her? No, we also tell her how to follow it up. So we usually ask her to come back for a OGTT, that is a oral glucose tolerance test, which we would like to do after the 6 weeks or 12 weeks when after pregnancy. So immediately after delivery, we are going to follow up by regular blood sugar estimations. And then once we recognize the blood sugar estimations to be within the normal range, then we tell her that there is no need of any medication for that particular diabetic status in that particular pregnancy. But then you also have to advise her that she needs a regular follow-up, because these women with GDM have a high risk of developing overt diabetes in future, especially if they do not make modifications in their lifestyle. So it is important that you have to tell them about, counsel them regarding how they should go about their lifestyle changes, like example, like exercise, weight loss, and the diet. These are the most important things we need to address. And the second thing is, again, you have to do a labs. So you ask them to come back after 12 weeks or so, and then ask them to go for an OGTT. If the OGTT is normal, and that means that the woman is not immediately likely to have, but then we never know about the long-term consequences. So we ask them to have a regular follow-up by doing for their blood sugar levels with any physician. They need not come back to the obstetrician, but let them have a regular follow-up of their blood sugar levels in the future. And the other thing we know, it is also associated with the hyperlipidemias. So it's also important that you follow up these patients with their lipid profiles when they are coming to you.